Before I hand over, I'd just like to introduce Professor Field to all of you. Hopefully some of you have met James before. James is somebody that I've had the pleasure of working with for a number of years. He's Director for Learning and Teaching at Cardiff Dental School, as well as a Professor of Restorative Dentistry and an Honorary Consultant in Prosthodontics. James has been a key opinion leader for Dentsply Sirona for many years and delivered training for us across, well, not just in the UK, but across Europe and the rest of the world. Delighted that he's joining us again tonight. So please, everyone, please do enjoy the webinar. Do chip in with any questions on the chat. And James, I'll hand over to yourself.
That's great. Thank you very much, Christian. Good evening, everybody. Do let me know if there's any issues with any of these slides. I can't see myself whilst I'm doing this, so do let me know. Hopefully you can see this okay. Yeah, as Christian was saying, this is the fourth and final webinar in this series, which is around back to basics. And as Christian was explaining, I'm based in Cardiff, and I teach undergraduates through core trainees all the way up through including specialty trainees as well. And one thing that is something that I see on a perpetual basis is just as people leave dental school, they start to forget some of the fundamental principles that underpin why we want to do things. So the main driver behind these series of webinars is to go back to address some of those again. And if you are relatively experienced in general practice, then maybe it might just trigger a few little thoughts around different concepts. And if you're recently graduated or haven't been practicing very long, then hopefully this will also reinforce some things which aren't that far away from when you were learning about them anyway, which will be good. So yes, this one is back to basics, and it's about anterior approximals. We had some webinars before that were looking at basic principles of treatment, treatment delivery, treatment planning. We talked about cement, lutes and bonds, and then the third one was about posterior approximals. So the focus tonight is on anterior, although what this is not is a webinar around the delivery of very high-end aesthetic anterior composites. That's not something that I do on a day-to-day basis. I obviously try to make my restorations mimic the environment they're going into as much as possible, but this is even more fundamental than that. This is about how to make sure that we have predictable restorations which have longevity. And in that sense, it's back to basics to learn about how we do that. So we're going to talk about fundamental concepts of anterior cavity design. And of course, here we're talking about when there's a need to cut operatively removed tooth tissue, most often due to the caries process. So when that's happening, how do we do that? How do we leave our preparation so that we have a nice, robust preparation that gives us a predictable outcome in terms of the restoration that we place? We'll have a look at the options, indications for direct restorative materials. I guess when we were talking about posterior, we have a few more choices because we're talking about dealing with the base of a box. We're talking about perhaps sometimes deep and the need to elevate margins. And also we're talking about being able to place large bulk amounts of composite, perhaps with bulk fills, and then a capping composite. And you might argue with anterior approximals that there's less need for all of those different stages, depending on how big the preparation is. But we'll talk about them a little bit tonight anyway. And then one of the things which is unique to this evening is talking about some of the challenges that we face when we have asked our lab colleagues to perhaps do some diagnostic wax ups, or we're trying to work with matrices to build up anterior teeth. So one of the common themes throughout these webinars have been talking about the success factors that will mean that the restorations that you place will remain in place for a long time. They will have the minimum amount of complication. And what that means is that they are retained. They don't have recurrent caries or micro leakage. We don't have sensitivity or marginal degradation and staining. And all of those things will contribute either alone or in combination to the failure of a restoration. So we can optimize our outcomes by doing a few things. First of all, we can make sure that we are minimally invasive and not removing tooth tissue unless we have to. We can make sure that we provide quality tooth preparations which meet recognized criteria. And if I'm honest, this is one of the areas where there is huge disparity in what happens in primary care in terms of how people are, not how they're removing caries, and sometimes not even how they're making decisions to operatively intervene, but what they're doing when they intervene. Where is the burr going? What cavity form is that taking? How are you finishing the margins, etc.? And we can also improve our outcomes by making sure that the matrix systems that we use are adequately adapted. And here we have a picture, obviously, of a posterior tooth and the Paladent V3 system. But tonight we'll be looking a little bit at different types of matrix for anterior teeth. Something which is really important is making sure that we are bonding optimally to substrates, be that enamel, be that dentine, or both, or other restorative materials, or combinations of all of those things. You need to make good decisions about which bonding strategy you're going to use. Still, so many operative dentists will pick up phosphoric acid and etch over everything before they begin, even if they're then going to move on to a more specific approach. And we need to get away from that habit of using such an aggressive acid on anything but enamel. And more than anything else, it's just a waste of material and a waste of process a lot of the time. And finally, we want to make sure that we contour and refinish our restorations appropriately. The very beginning of this webinar series is really all about what we're doing now that we don't have amalgam to use anymore. And the great thing, in my view, about amalgam is that you overpacked and you carved back. And there was a real art associated with that, in that you could really reliably pack the amalgam into place. You could crunch it down really hard to get a good contact point to make sure it was well adapted. And then you could spend a period of time carving your shapes back in. But with composite, it's almost the opposite. We can't pack firmly. So we need other ways to make sure that we have good adaptation. And we should finish our composite largely in the way that we intend it to be finished when we cure it, rather than expecting to cut things back, which actually can be quite difficult. Using a half Hollenbach or a Ward's carver to carve amalgam is very different to using a rotary instrument to try and cut back composite. So we'll talk a little bit as well about how we can make sure that we do that. And finally, the other way that we can optimize our outcomes is actually by effective treatment planning. It's about ensuring that we can make appropriate decisions for how predictably restorable teeth are. And again, I've said this throughout all of the webinars, but I don't think that we do this well enough as a profession, is obtaining suitable patient consent before we make decisions around the restorability of teeth. So we'll talk a little bit about that as well. So before we go much further, we're going to have a little look again at ICCMS. And if you came to the other webinars, then you'll hear this again, but I don't make any apologies for that because it's really important. And ICCMS stands for the International Caries Classification and Management System. I hope that most of you have come across this, certainly at undergraduate level. But if you haven't, it's actually really quite a useful system for how you detect and diagnose caries, how you plan interventions, and then how you assume risk and recall after that. There is a different system which you may have come across, ICDAS, which is the International Caries Detection and Assessment System, which is a system for classifying and assessing. The ICCMS overall is for managing caries based on risk assessment and prevention. So you can visit these online. You can find them relatively easily through a Google search. And there is a very large document which takes a long time to work through, but it has some really, really important stuff in it about all of these different sections to do with caries management. And there are also some very good sections towards the back end of the document around how to make categorization of the caries process based on different clinical presentations, but also radiographic presentations as well. So I've put the QR code back up here again tonight to take you to that. It should take you to the PDF. And as you scroll down towards the bottom, you should start to see the different ways in which things are categorized and classified. But we did cover that in the previous webinars to a greater extent. So if you want to go back to look at those, then you're very welcome. One thing I do want to talk about just now is resin infiltration, because as we want to become more and more conservative, preservative, and less invasive, then it's something which is gaining more and more traction. And it's worth mentioning resin infiltration because it is part of one of our tools that saves us from making operative interventions by way of removing tooth tissue, certainly if we've got areas that are hypermineralized. And it's worth considering this. I'm not really going to talk too much more about this tonight, but it's worth bearing in mind that there are systems out there for infiltrating resin into hypo or demineralized enamel. And this paper itself here is well, it was hot off the press when I wrote it. I guess it's probably just over a month old now. But again, I've put a QR code up here which will take you to the paper. And what this is saying is that, we know that just before we get cavitation, that we can treat aproximal carious lesions with these non-invasive measures. And it's very well demonstrated now that they arrest progression and they can enhance remineralization. But that has to be really alongside the usual preventive measures of tailored oral hygiene instruction, dietary counselling, and delivery of fluoride. So there is also a need here for continued patient-centric preventive advice and fluoride as well. And a quote from the paper here: "It's important to remember the significance of postponing the first restoration for as long as possible. No restorative procedure is permanent, so each time a tooth is restored, a recurring cycle of interventions commences." And yes, we try and give this message as often as we can. And those of you which or who are seasoned practitioners, shall we say, will very much appreciate this viewpoint. And if it was your own mouth and your own teeth, then hopefully you would want to hold off operative intervention as long as possible. But this very much should be our philosophy now, and we should be trying to avoid operative intervention wherever we can. I'm doing myself slightly out of a job there because I'm a restorative dentist, not a preventive dentist. But yeah, we shouldn't really be removing tooth tissue unnecessarily. So if we think about cavitation, again, I've put a little QR code up here because I gathered some of this material from the Style Italiano resources about what happens when we do have cavitation of the aproximal lesion, because at this point we need to think about how we're going to operatively intervene, how we're going to operatively prepare that tooth tissue. And one of the things I'm going to talk about next is well publicized. It's taught almost as standard in pretty much any dental school, but it's what a quality preparation looks like. And what does the evidence suggest that should look like, and how should we prepare it? And if we go back to remind ourselves, then there are some fundamental things that we have to do if we have a cavitated aproximal anterior lesion. And that's that, first of all, we have to remove the unsupported and the degraded tooth tissue. And we have to do that not just directly, but we have to do it in such a way that it clears the contact point, because the contact point is the area around which and just below which the caries process will begin. So we want to do that as conservatively as possible. And what you can see as a reminder on these pictures is that if we are approaching the anterior tooth from the palatal aspect and we are perpendicular to the palatal surface, and we are operating in the middle third of the crown, that we will essentially operate through to at and around the contact point. And we can be protective to the adjacent tooth by leaving a very thin sliver of aproximal enamel, which can then be either fractured away with hand instruments or carefully abraded away with the rotary instrument itself. And really, that should be slightly wider at the base with a minimal palatal access, and we should have cavo surface angles which are around 90 degrees. Now, these things are really important. A lot of people will say things like, well, why does it need to be wider at the base? Why does it need to be undercut? Why does it need to have robust cavo surface angles if we are placing composite, which is adhesive? And largely that argument comes from a cohort of practitioners that historically have used amalgam for a lot of their restorations. And usually my response talks around the fact that when we look at how restorations survive, particularly composites, there are two components to this. The first one is how they have a border seal and how they're retained. And the other one is how they behave under loading. And if your restoration has a robust preparation beneath it, then it will put less strain onto the peripheral lute, the peripheral integrity, and the overall way in which it's bonded to the tooth tissue. If you have poor resistance form in your preparation and you have unsupported tooth tissue, then it puts extra strain onto your micromechanical bonds, which means that you're more likely to get marginal degradation, marginal staining, microfractures, and sensitivity. So some things to really remember: we have to clear the contact point. We really want cavo surface angles of around 90 degrees. And of course, we want to protect the pulp. We shouldn't be starting too far into the body of the tooth, and we shouldn't be outside of that middle third of the crown. Otherwise, we start to work through tooth tissue, which is quite thin towards the incisal edge and misses the contact point, or we are too inferior and we're working through very thick amounts of tooth tissue, which probably will compromise the pulp in some way. We don't really want any tooth tissue to be unsupported. And as I said before, there is some value in having a degree of undercut, not by design, but I guess it's there as a result of clearing away affected tooth tissue, but maintaining a minimal palatal access. But the undercut will really help to retain your restoration mechanically, macromechanically, and it also means therefore it'll place less strain on your resin bond, particularly at the margins. So I'm just going to pause and have a little think about some research in this area. And one of the papers that I've chosen here is by DeMarco and the team. It's 10 years old now, but it's still a good paper, supervised by Nick Opdam. And what this article talks about is the longevity of anterior composite restorations. Now, you wouldn't really believe this, but there's virtually nothing else out there since that time, which, given the move towards composites, is a little bit surprising. What it's showing is that generally anterior approximal composites demonstrate fewer failures than composites in other locations. That's not a huge surprise to me, because the way that restorations are loaded anteriorly, approximally, is really very different to how they're loaded posteriorly. And there are a few studies that actually look at the failure factors rather than the actual failure rate itself, which makes this even more difficult to try and unpick. But as we've said before, what's really important is marginal failure. If you start to get marginal degradation of a restoration, then that's a huge sign that you're going to get future problems and increases the chance of overall restorative failure significantly. What the study also shows, and we know from a lot of these studies, is that there are a huge range of adhesive techniques and approaches, which makes comparing these, particularly in this context in a systematic review, very tricky, because the parameters are all different. And what we can infer from the data is not as robust if people are using different techniques and different approaches. Obviously, we know that we're using composite resin, but again, even the materials themselves are made up with different compositions. So this is what makes it tricky. Also, the study looks at the time required to place restorations as well. And we know from some of the work that's been done by Dentsply before that time is a big factor in terms of how practitioners engage with composite restorations. And what this series of webinars is doing is also trying to give you a predictable and robust approach, which does save some time without cutting some corners as well, particularly if we go back and look at the strategies for employing combinations of bulk fills and also kind of bonding agents, which are multimodal as well. Interestingly, the paper doesn't really talk about isolation in any way in terms of approaches, which some people would argue is quite a significant factor when you're looking at factors to do with long-term survival and reasons for failure. So at this point, I just want to turn to sustainability. It's a common theme that I've put into all of these 4 webinars, and as students going through the system at the moment, then you will receive a reasonable amount of information about this now. But for those of you that have graduated, you might find it more tricky to find information about sustainable practice. So trying to bring a little bit of that to the webinar tonight. And I showed this paper in the previous webinars, but really this is an important paper by Brett from Trinity College Dublin, which is looking at how environmentally sustainable dental treatments are, or the delivery of dentistry is. And most people think when you ask them around the impact of delivering dental care, this is around kind of chemical waste, plastics, single-use plastics, etc. But really, the biggest carbon footprint in oral healthcare comes from travel from patients and staff. So over 64% of that carbon footprint. And that's really, really important to recognize, because anything that we can do that reduces the amount of times that patients travel to us will significantly reduce our carbon footprint. When you couple with that the fact that we know when we're using composite that one of the biggest reasons that composites fail in some way is due to inappropriate bonding protocols. So here we are tonight talking about composites, but webinar 2 was talking about cements, lutes and bonds. And it's really important to go back, if you didn't see that one, to look at what are the appropriate bonding protocols to make sure they're optimized. And the key message then here, and again, I make no apologies for saying this again, as I've done in the other webinars, is that we need to do it right first time to reduce the incidence of patients having to come back or us having to make other interventions. I have a few slides here that I normally talk to educators about, but I've put them in here because I think they're really useful if you are interested in sustainable practice and perhaps don't know so much about it. So there's some work from one of my junior colleagues here, Johnny Dixon from the University of Sheffield, who's done some incredible work along with his supervisor, Nick Martin, and myself and Emma Gibson, looking at how we teach the next generation of oral health professionals to practice sustainably. And again, if you follow this QR code, it will take you to the FDI website. And what Johnny's done is he's taken a lot of the work he did in the educational environment, and he's made some resources with FDI available, openly available, both for professionals, but also for the public and for patients. And if you go to that site, you can read about the different summits that have happened in terms of sustainability, but you can also go to the educational resources on sustainability in dentistry. And the reason that's useful is because, again, it's meant to be for educators, but you can go to different disciplines of dentistry and you can read different statements around how we can be more sustainable. And, I think this is perfectly valid for people who are practicing already to go and have a little look at that. You can click on just a screenshot here of what it looks like, but you can click on the different fact sheets for different disciplines. And there's some slide decks there as well, but you can read again about how you can perhaps make sure that you're being as sustainable as you can in those different disciplines. And there are also some statements on there on how it maps across. And if you were really interested, then there are some links there that take you back to the original published papers and the evidence base that supports each of those statements. Again, just an example here of the tables, the statements, and the disciplines in which it's relevant. So I won't say too much more about that, but I think it's good if you're interested to have somewhere to go. And now that's not been there long. It's probably only been there a few months. So it's a very good resource. Interestingly, when you're there, you do find other stuff that draws you in a little bit. We have a massive open online course there that you can do, and there's a toolkit as well to do with sustainability in dentistry, and you can also look at different awards that exist. But anyway, let's move on now beyond that to the rest of this tonight. So let's look at the clinical solutions, how we can make sure that we have predictable, robust anterior approximal restorations. Well, we talked initially about needing to make sure that we're minimally invasive. And the question really is, what does minimally invasive dentistry mean? The definition is a systematic respect for natural tooth tissue. But sometimes I find that when we speak to people about this, it's not really clear what that actually means in practice. I guess basically it means not picking up a burr and removing tooth tissue when it's not absolutely necessary. But the question, I guess, then is what is necessary? If you've seen the other webinars, you'll have seen these slides too. But in this case, where the patient is suffering from amelogenesis imperfecta, and they have had multiple attempts with composite restorations, the next stages to give predictability may not be minimally invasive in some people's eyes, but it is as minimal as it can be to give robust solutions. And full coronal preparations in this case will mean that those teeth are lasting a lot longer than they would if they were left in this condition. It's not minimal in terms of its comparison to other treatments, but it's minimally invasive in this specific case. And you can imagine how placing composites onto this affected tooth tissue is not a very predictable thing to do. And you can see some of the composites that have been left behind and the others have been lost completely. So minimally invasive dentistry has to be prescribed on a patient-by-patient basis. Coupled with that, though, is our ability to bond optimally to different substrates. And your bonding strategy makes a big difference in how you can maximize all of those different surfaces, how you can cater for preparations which become over wet or over dry. As we've said before, how you can optimize the marginal integrity of your restorations and minimize post-operative sensitivity. And it's products like Prime Bond Active that will really allow you to do all of those things. Webinar 2, if you didn't see that, has a lot of videos in it and animations around how this product works. It's a very clever product, but it will give your work predictability. And we use this amongst the other Dentsply workflow entirely for teaching our undergraduates because it's a very predictable solution. And it's something which makes a lot of scientific sense. But we covered this previously. So if you wanted to, you could go back and look at that webinar again. I also talked last time about contouring and handling. Very important. If you can't contour your restorations properly or handle the material, then you end up having to do a lot of extra work, both in terms of placement, but also in terms of finishing and polishing. So your choice in terms of the composite that you use will determine how well you can sculpt material, how well it adapts to your cavity form, how much it slumps, which might not be such a problem with anterior approximals, probably more with large posterior or large approximal, large occlusal restorations, and optimizing aesthetics as well. And you can see on this slide here, we've got the Spectra ST family of products, which are the standard ST. We've got ST Effects, and then we've got the flowable. And then we've got SDR flow, which is a bulk fill flowable, which comes in a few different shades as well. And with anterior approximals, it may really be the case that you don't necessarily need to combine or have the scope to combine these materials. You might just be picking up one or the other. But either way, you would hope that when you finish placing these, that there's a minimal need for polishing, particularly with anterior approximals, where largely what you're restoring is a smooth surface. Really important in that context to get the correct matrix in place. If we're looking at the Spectra ST family itself, I've put a little QR code here to take you to the website. And if you don't use these already, again, very intuitive family of materials, but also employing the cloud shade system, which is really interesting and very useful to save you having to stock a huge number of different shades, which largely, inevitably, you won't use all of them all of the time. So you've got a simplified shade matching approach. I personally think this has excellent adaptation sculptability as a mainstream restorative composite material. You get a bit of choice in terms of the choices in viscosity, and you get very aesthetic restorations that are durable and they last. Again, we're not talking here about very high-end aesthetic results, class 4s and wear cases where we want some real kind of characterization. But this simplified shade approach, the cloud shades, will mean that you get a very aesthetic result with minimal effort. And again, we can use Spectra ST simply, if we wanted to, posteriorly as a capping restorative, but it can be used wholesale for anterior approximals. I just want to make small mention about marginal adaptation again, because again, this is something which will determine our marginal integrity, and therefore, based on fundamental seminal research papers, will determine the final longevity of our restorations. And again, you may not be using SDR flow anteriorly, you could, but you may be using Spectra itself. But either way, the advantage here of SDR flow is that it does exactly that. It will adapt extremely well to cavity form. And you can see on the pictures here, on the left, we've got kind of a standard composite being applied into a cavity. And on the right, we have SDR flow, which doesn't slump when it's in place, but it will adapt to the internal cavity form. And if you want to really get a normal packable composite to adapt to that, then you have to do a few things. You either have to agitate it in some way, pack it physically, or you have to warm it. And even then, you won't get the full adaptation that you get with SDR flow. But all of those things take time. And SDR flow is itself, it's very wettable. It takes itself into those cavity spaces and adapts itself without slumping. If you look at the pictures above again as they change, you can see what that marginal adaptation looks like when the material has been at the margin. And with a packable composite, you get a reasonable adaptation. But with the SDR flow, you get a really, really accurate representation of the margin. So moving on, let's have a little look again at some relevant research. And here we're going to look at the seminal work by Hayashi. And I've been talking a few times tonight about that marginal integrity and why that's really important. And that's what this paper is showing. So it's really important not just to keep the restoration into place, but if you've got good marginal integrity, then you're going to reduce the micro leakage and you're going to reduce the marginal degradation. And you'll also reduce the chances of marginal staining. And the studies that Hayashi did show that restorations that have marginal deterioration at 3 years were 5 times more likely to have failed by 5 years. And going further, the restorations that have marginal deterioration and discoloration were 9 times more likely to have failed by 5 years. So, I mean, this makes a lot of sense to me as a clinician, but also as an educator, when I'm trying to explain this to our students. But yes, you need a marginal seal. You need to retain the restoration in place. But the degree to which you optimize the marginal integrity is an indicator for so many other things to do with that restoration. Micro leakage, sensitivity, and finally, overall degradation and loss or failure of your restoration. So Dentsply, of course, done some of their own testing in the lab, and this slide is just some of the studies that were published in the Journal of Dentistry, looking at SDR flow and its kind of behaviors. And what it was showing against the materials tested was the lowest shrinkage stress of all of the bulk fill materials that were tested at the time. And this is getting up to almost 10 years ago now, but really important to understand that is also a factor here, is shrinkage stress. when placing composites, and we want that to be as low as possible. And what you can show in these papers is that the bulk fill technique at 5 years wasn't statistically significant, maybe slightly better durability compared to conventional incremental layering of composite resins, and no postoperative sensitivity. But what that's basically showing as a result is that you can use a faster solution here with no significant difference in clinical outcomes. So what I'd like to talk a little bit about now is how we sometimes use anterior wax-ups and matrices to help us place our restorations. And I've put this in because it's becoming more and more commonplace for us to have to restore moderate tooth wear, sometimes severe tooth wear. And this links quite well to what we're talking about in terms of fundamentals. NHS practice doesn't always lend itself to the optimal workflow here, but really, if we want a wax up doing, so we can discuss the outcomes with patients, and we can use it to make matrices, both for mock-ups in the mouth, but also to help us place composites, then we need to take the time to take good records, and to have wax-ups done and sent back to us first by the lab. But that all adds in time, it adds in stages, and we need to be prepared to put those options to our patients. If you're doing more extensive composite restorations, then I would definitely advise people to work from a diagnostic wax-up, and you can see the picture here, a tooth wear case. We've had our lab technicians to wax in or back in some tooth form, perhaps not quite to the length the teeth were originally, but a little bit of height there to restore some form and function and aesthetics at a prescribed occlusal vertical dimension. But what that wax-up is allowing you to do is to talk about the aesthetic outcome with the patient. It's allowing you to make a matrix directly onto it, which can assist with the placement of the composites. What I'd really like to say, though, is that you have to be really careful with wax because it's translucent. It can look very nice on these pictures and in your hand, but actually when you look more closely, the translucency of the wax can hide a multitude of sins. And actually, if you have your wax-ups duplicated in plaster or stone, particularly if you're having some kind of suck-down splint made on them, then it does start to show a lot of problems that might exist with wax-ups, which the opaque plaster and stone makes much more visible. And you can see some examples here of a few little voids in this wax-up, some not very well defined interproximal contouring, and some ledging as the wax meets the tooth structure. They are just more close-up photos that are taken from that same wax-up. So it's really important to pay close attention to that, because if you use a matrix to place these composites, then they will have exactly that contour. And you won't necessarily see it if you've got high-end loops. You'll probably see those discrepancies, but not always. If you are making an anterior putty matrix, then there's a few things to bear in mind. In my experience, through teaching this, a lot of people make matrices which are too small. They're either too small or they're too big and they cover everything. And then people fail to be able to seat them and to be able to actually even get the composites into place. So a few things to bear in mind: that you do want full coverage to maximize the stability, but it's not full coverage of the teeth you're restoring. It's often full coverage of the adjacent teeth and the mucosa. Don't forget, with wax-ups, the wax isn't on your natural teeth. So if you're making your matrix on a wax-up, don't rely on the wax itself to stabilize the matrix, because you'll go over to the mouth and that matrix will just rock on the mucosa because there's no wax there in the mouth. So you need other surfaces to obtain stability. For me, it's largely the premaxilla and the palatal vault, and possibly the palatal aspect of some of the teeth, which are not being waxed up. You need a bit of pressure as well to apply the putty interproximally to obtain good detail. And you can see the difference there on the left and the right between the interproximal detail that we might have. That's really, really good to get. And make sure that you pick up the incisal edges as well. And I see a lot of people with a scalpel that actually end up cutting away the incisal edges, perhaps by accident, but also not realizing it. So make sure you curve a little bit around your wax up to pick up those incisal edges. And also something which isn't done very often, a lot of people will make a putty matrix on the bench and they'll apply the putty over the cast. But if you actually put a couple of finger holds into that as it's setting, then it makes holding it in the mouth extremely easy compared to a fairly rounded or slippy contour, which you get if you just make it rounded on the bench. And looking at this now, I've probably realized that somebody could probably take my fingerprint and do all sorts of things with that, because as I was demonstrating this, I obviously didn't have any gloves on. So there you go, Christian. There's a data breach there. Got my fingerprint out there in the world. A few other points about anterior matrices. Again, I am not the person to be talking to you about very high-end anterior aesthetics, but again, some things which, when we're teaching at postgraduate level and undergraduate level, which are common mistakes, are worth mentioning, in that when people are applying the matrix to the teeth and then applying the composite, it becomes difficult if the matrix is already in place. What I prefer to do is to mark on the matrix the point at which the tooth structure ends, and to apply a very thin film of composite onto your matrix first, bringing that up to the tooth. But what I would always do, as you can see in the top right picture, is to leave a very thin gap so we don't have direct contact of the composite with the adjacent tooth. What that means is you don't run the risk of bonding to the adjacent tooth. And then you can apply your composite strip, your interproximal strip, and you can restore that last small increment. But that's really important, otherwise it can become a bit tricky. And also, you want to make sure that a matrix you are using is held in place very well with a wedge system. And we'll have a look in a moment about some of the different types of matrix that you can use. But make sure you mark the restoration boundary on the putty, very thin layer of Spectra ST, avoiding the interproximal area, and then apply the matrix to the teeth. And when you light cure and remove the matrix, then as you can see in the top right, that palatal shell of the ideal contour from your wax up will remain in place. What that then means is that you continue freehand and using your matrix to restore interproximally and the smooth surface and the incisal edge. Some other ways to go about this, I've tried some weird and wonderful ways across my career, but one of those is a Memesil matrix, which does allow you to light cure through it. One of the challenges sometimes, depending on where your wax needs to be, is that it isn't just an incisal edge. And so using a matrix to help you build it up can be challenging, because it also precludes you actually being able to light cure that composite. So you can use a Memesil matrix, you can light cure through it, and you can also, if you wanted to, you could embed, in this case, a metal matrix strip that you've picked up from the wax up in the Memesil as well. So when you go over to the mouth, you don't run the risk of bonding the adjacent teeth together. We see a lot of people now using kind of injection molding techniques, etc. And they're all good in trained hands. With our students, they're a nightmare in terms of things flowing into areas you don't want them to, and teeth being bonded together and interproximal spaces suddenly disappearing. But the Memesil matrix approach here is a reasonable halfway house if you wanted to try that. Memesil, in case you didn't use it or know it already, is a clear bite registration material, which is fairly rigid when it's set. If you did want to also use PTFE tape alongside this, it does make it quite challenging to then seat the matrix. So it's just worth bearing that in mind. But with all these things, you just have to have a go, have a play, see how it works in your hands. Again, I've taken some of these pictures from Style Italiano, but we've got other types of sectional anterior matrix which you can use. And as you can see on the picture here, giving you very nice contour. And the only thing, again, you need to make sure you really do is to adapt that matrix at the base of your restoration. That's really, really important. They can be metal or clear. There was a bit of work, a bit of a fuss made maybe a decade ago about using, particular wedges which transmitted light to the base of the box. I'm not particularly convinced about the need for that. I think it's quite safe, especially if you are using bulk fills or you're incrementally building your composites, that you could use metal or clear matrices in relatively small restorative spaces. And of course, you could take other matrix systems that exist and you can modify them. Sometimes we take the clear interproximal Howe matrices and we trim them with a curved edge and flute them and sit them back down again against the aproximal surface. There are some of the matrices, Unica matrix that you can see here, which surrounds the whole tooth, particularly useful if you've got multiple cavities to restore. But again, really important that you've got a wedge there, which holds that space and the matrix against the tooth, particularly firmly as well. Other options, though, without a wedge are liquid dam, or something which I used to use when I used to do a lot more direct restoratives, was actually temporary inlay materials like Systemp or Telio. They're particularly useful for kind of packing in to that embrasure space and light curing. They're obviously not as rigid as a composite, but they're rigid enough to hold things into place. You can even burnish shape into your restorative matrix before you light cure, and it'll hold that position. And then you can pick out the temporary inlay material afterwards to release the matrix. A little bit of a workflow here from the Dentsply team around, again, using some of these systems. Again, we've got the transparent matrix here, which has been appended and sitting down into the sulcus. And again, we've got some of the temporary inlay material that's being used interproximally, as I've just described, that's holding that space. We're using, in this case, a little bit of ceramics, but it's essentially a packable composite. But again, in this context, you could use Spectra ST flow. You could use something which is flowable in that area. But again, you can see the value there of that interproximal holding of the matrix. And unlike a wedge, the Systemp or the Telio is allowing you to contour and burnish up to the contact point that clear matrix to give you a good outcome. You can see that there once it's been removed. And the final image. So coming back to sustainability, I want to talk about polishing, and I did mention this last time, but I think it's really important. We think about amalgam and the potential effects that could have had on the environment or did have, and how we used to collect it with amalgam separators in the UK. And in some senses, we were ahead of a lot of parts of Europe, a bit ahead of our time, really, in terms of how we mandated that across all of our dental practices. But the bigger problem now is actually in composite particulate and dust. You can see some of these systematic reviews and meta-analyses here around the generation of dust as composites are polished. Some of the work from Dentsply from a long time ago shows that polishing of composites occupies around a fifth of the clinical procedure time. But if you try and equate that to how much waste that's producing, how much particulate waste, then that's quite significant. When you think in dentistry, then that particulate waste isn't filtered, it goes straight into the water course, then that's really quite important to understand. And this paper is showing that all types of composite release significant amounts of nano-sized particles, and they're shown to have negative effects on bronchial epithelial cell viability. So not only is it important that we minimize this for the environment, but it's also important that we minimize this actually in the mouth as well. So here we want to reduce biological effects, both in nature and for the patient. Separate paper by Steve Mulligan and the Sheffield team here with Kay Van and Nick Martin, showing that those microparticles from resin-based composite allow leaching of monomers with potential significant environmental impact. And again, if you read the paper, you can see how and at what level they're able to detect those monomers. And, you know, if you scale that up across dentistry worldwide, then that's really quite significant. And here what we want to do is we want to reduce waste as much as reducing the environmental impact of the chemicals. As we come towards the end, I just want to mention finishing again. And I always make this point, but there's a big difference between finishing and polishing. really, if you want to change or continue to change the actual shape of what you've done, then you will need to use very coarse discs or strips, or you'll need to use rotary instruments. If you then want to have a finishing polish on your restoration, or a final polish, then you'll need to use systems which have a much finer grit or roughness, often perhaps with a paste that might give you a kind of luster on the surface. But often people combine the two and will either try to change the shape of restoration, but with something which won't because its particulate is too fine, or are not intending to change the shape because they want to polish something, but actually are changing the shape of their restoration. So in many cases, the lines are blurred here with what people are doing. But to polish, you need three-body wear. You need something in that system to change the surface finish. And typically, historically, this was often done with kind of pastes. But the enhance system from Dentsply Sirona is a fairly useful system, because in the past that's meant working through a range of discs or strips from coarse all the way up to super fine. But what the enhance system allows is for you to finish in one step. And the way that works quite cleverly is that by applying more pressure, the system actually moves from polishing towards surface change with more pressure. And as we put less pressure on, then it begins to polish again with a fine finish and surface luster. So it can be a way of reducing clinical time for giving you the finish that you want, not least reducing the number of components that you have to work through to get a nice surface finish. So in summary then tonight, what are my key messages? Well, the first one then is, again, to only remove tooth tissue when it's absolutely necessary, and also to prepare anterior approximals that actually do have resistance and retention form in them, and really thinking about not just getting in there and removing affected tooth tissue and degraded tooth tissue, but thinking about your actual cavity form. Ensuring that marginal integrity is maintained, not just by your cavity form, but through your bonding protocols and through your adaptation of the material, but also planning the use of matrices and wax ups appropriately. So we were going to talk about the fundamental concepts of anterior cavity design. We were going to talk about the options and indications for a range of materials and techniques, and we were going to explore some of the challenges of working with matrices and diagnostic wax ups. So I hope that that's been useful this evening. I'm going to stop sharing my screen, and if any of you have any questions, then I'm very happy to chat through some of those with you, and I'll hand back over to Christian.